Okay. Okay. Good evening, everybody, and good morning on the other side of Atlantic. It's a pleasure for all of us to have this session, and my thanks to Mr. Rajiv, who single-handed did all this arrangement. He spoke to me a couple of times, and it's a really honor to be a part of the faculty. Uh, Having said that, it is again honor for me to introduce Professor of Pediatrics, Dr. Eduardo Benclari. Dr. Benclari actually was my teacher long time ago when we have VIP bird with assist control, and we were very excited that we have a new mode. So don't guess my age, but it is at that time when we have that ventilator, and the Dr. Benclari come to our unit in North Shore University Hospital in New York to teach us. Dr. Benclari is the professor of pediatric obstetrics and gynecology and director of the division of neonatology, Miller School of Medicine at the University of Miami, chief of the newborn services at Jackson Memorial Hospital, Miami, Florida, USA. Uh, Everybody know Dr. Benclari. He's the author or the co-author of more than 200 papers and 60 books chapter in the areas of neonatal respiratory physiology, lung injury, and respiratory care. In addition, Dr. Benclari and his collaborator had developed one of the largest and most prestigious neonatal programs in the USA at the University of Miami Jackson Memorial Hospital. Dr. Benclari and Dr. Charles Bauer are the two organizers of Miami Neonatology, one of the longer lasting neonatal conference. To my knowledge, it is the longest lasting neonatal conference, which actually about 39 years going on. And many of the great neonatal faculty involved in this conference, and it participants from more than 40 countries. So without further ado, because if I want to introduce fully Dr. Benclari, it take another time for another talk. I will ask Dr. Benclari to give us the prestigious talk. But before that, I have to announce that Dr. Benclari has to leave. So we will do the question and answer session after his talk. So if you want to ask any question, just write it down in the Q&A, and I can relate to Dr. Benclari. Dr. Benclari, good evening from here and good morning to you.
Good morning, good evening. Thank you very much, Dr. Khan, for your kind introduction. Thank you, Dr. Rajiv, and congratulations for organizing this fantastic get-together to discuss bronchopulmonary dysplasia. By the way, I think I will be able to come back to the discussion later during the day, so I will be happy to participate in the panel. Thank you very much. So I am going to talk about bronchopulmonary dysplasia. That is one of the complications of prematurity, as you all know. And the focus of this talk is going to be mainly on prevention of BPD, but to understand prevention of any disease, we have to understand what are the main pathogenic mechanisms. And that's why I'm going to spend the first half of my talk discussing pathophysiology of bronchopulmonary dysplasia, and then we'll go into some of the steps we can use to prevent the disease. BPD was described in 1967 by Dr. Norsway and collaborator. Dr. Norsway, as you know, is a pediatric radiologist at Stanford. And essentially, he was the first one to describe this disease.
Dr. Benclari?
Yes?
Your screen is stuck. I hope, Doctor, the presentation is not coming.
Excuse me?
Yeah.
Your presentation.
Dr. Benclari. Yeah, the screen is not coming up. Can you share your slides again? Because I think...
I am sharing the screen.
Email. It's not the presentation, Doctor. Can you stop and start again?
Okay, well,
Yeah,
I stopped.
and then
We'll start
share
again.
again.
Yeah, please.
Okay,
Sorry
share.
about that.
Are you okay now?
Here we go. Yes, here we
Okay.
go.
Okay, perfect. So the disease was described in 67, as I mentioned, by Dr. Northway. And what he did was to describe a group of 32 infants who survived or died after prolonged mechanical ventilation. And I have to remind you that at this point, mechanical ventilation was done in babies with severe HMD because we did not have a surfactant and these babies did not get antenatal steroids. So you can see here that the settings that were used in the ventilator were extremely high, peak pressures of 30, 40 centimeters of water, and these babies usually spend weeks on 100% oxygen. Now, why this disease was not described before? Very simple, because before mechanical ventilation was introduced, as Dr. Vidyasagar mentioned, the mortality of babies with severe RDS was extremely high. So it was only after some of these babies start surviving after mechanical ventilation that BPD became a known entity. So it's more than 50 years now that Dr. Northway described bronchopulmonary dysplasia, and we are still talking about this. And why do we talk about BPD? First, because it is a very common complication. 30 to 60% of all extremely low birth weight infants who survive beyond 36 weeks have BPD. Second, it's a very difficult disease to prevent, as we will see during this entire presentation, and it is associated with increased mortality and morbidity, including increased risk of neurological poor outcome. The other problem, obviously, of BPD is that being a chronic disease, it prolongs hospitalization, and this increases dramatically the separation between patients and families. This also increases the utilization of medical resources. So here you can see the incidence of BPD in relation to gestational age in data from the NIH network. And we can see like many other complications of prematurity, BPD is clearly associated with the degree of prematurity. A baby who is more than 28 weeks has a relatively low risk of BPD, while a baby who survives after being born at 23, 24 weeks has a risk of BPD of close to 70, 80%. So prematurity has a very predominant role in the pathogenesis of bronchopulmonary dysplasia. This slide was shown already by Dr. Vidyasagar also. And the other reason then why we're worried about BPD is because in many units, it seems that the incidence, instead of decreasing, like many of the other pathologies of prematurity, the BPD incidence is increasing. I personally, I'm not sure that this is really entirely true. I think that part of this has to do with the ways we define BPD, and part of this reported increase is also related to the fact that smaller babies are surviving with more frequency today. So in terms of long-term consequences, as I mentioned, BPD is associated with a number of complications. One of them is chronic lung disease, and specifically chronic obstructive pulmonary disease. And most follow-up studies of babies with bronchopulmonary dysplasia show the same data that was presented by Baraldi from Italy many years ago, showing a persistent decrease in forced expiratory volume at 1 second, indicating that these babies remain with airway obstruction for many, many years into adulthood, and therefore are at higher risk for developing chronic obstructive pulmonary disease as they age. There is also data that diffusion capacity is decreased in these babies, and this reflects the decreased surface of alveolo-capillary surface. Now, there has been substantial changes in BPD, and this has created some confusion in the definition of this entity. And the changes, I think, have been in the right direction, in the positive direction. On the left here, you have what happened with babies with the original BPD. who required very high oxygen and high settings in the ventilator because they had severe RDS. And they developed this significant disruption of pulmonary architecture with areas of emphysema, fibrosis, and atelectasis, and many of them developed also significant pulmonary hypertension with cor pulmonale. The histology of these lungs, mimicking what you see on the X-ray, showed significant areas of emphysema surrounded by areas of collapse, and also very dramatic changes in the pulmonary vessels with increased smooth muscle. Same thing happened also in the airways, explaining the high airway resistance that many of these babies present. With the introduction of antenatal surfactant and with the introduction of antenatal steroids, the degree of severity of RDS was substantially reduced. And this led then to a change in the clinical presentation of these babies with milder RDS, but still, during the first 2 weeks of life, these babies presented with this deterioration in lung function and increased in FiO2 requirement. And they end up also with chronic oxygen requirement, chronic respiratory failure. But in these babies, as we know, that is known today as the new BPD, this term was coined by Alan Jobe, they have much less severe derangement of the lung architecture. It's a more diffuse disease, no significant areas of emphysema or fibrosis, and the pathology of these lungs is completely different from the pathology of the classical original BPD. The pathology of these lungs is mainly a reduction in the alveolar septa. In other words, there is an arrest of septation. These lungs do not form normal alveoli the way it should happen during gestation, and therefore these babies have smaller numbers of alveoli, of larger units, and if you estimate the alveolo-capillary surface in these lungs is reduced. And that explains then why these babies also have hypoxemia. So what happens essentially with a baby who is born at 23, 24, 26 weeks, that are most of the babies who are developing BPD today, is that these babies are born in the canalicular or saccular stages of alveolarization. They really don't have alveoli, they only have terminal sacculars. And at this point, these babies who are supposed to be in utero with their lungs practically not moving and with fluid inside the spaces, these babies are suddenly exposed to gas breathing, they are exposed to high oxygen concentrations, and they are exposed to constant pounding by our efforts to ventilate them with positive airway pressure. All these dramatic changes that are quite different from what is supposed to happen in these lungs produces an arrest or at least a decrease in the production of alveolar septa. And therefore, these babies do not progress to a normal full alveolarization that should be observed around 38 or 40 weeks, but they remain with lungs essentially that are poorly alveolarized. And as I mentioned before, this explains then why they have stiffer lungs, why they have increased airway resistance, and why they have chronic hypoxemia. So BPD today is essentially a chronic respiratory disease of preterm infants, mainly extreme preterm infants, that is due to abnormal lung development. It's not so much related to the injury that we saw in the original BPD, but it's an alteration in the normal development of alveoli and capillaries. And these lungs then remain relatively immature. And if we think this way, we have to realize that most preterm infants, most extreme preterm infants will have some degree of alteration in lung development, and they really will have some degree of BPD. So the issue today is not so much which extreme preterm infants have BPD, but what is the severity of the lung damage that these babies develop. This alteration in alveolar development has been investigated in experimental animals, And you can see here the main factors that produce alteration in alveolar development. Preterm birth and gas breathing is without any question the most important factor. Then lung injury related to mechanical ventilation, overstretch, high oxygen concentration, and infections are the other factors that alter alveolar development. As Dr. McNamara mentioned, increased pulmonary blood flow can also produce damage of the capillaries in the lung and produce an arrest of lung development. And there are also a number of nutritional deficiencies, protein, vitamin A, and vitamin D, that are also associated with poor development. What is interesting is that steroids given antenatally or postnatally in large doses and for long periods of time can also produce an alteration in alveolarization. And this obviously is very worrisome because we are using antenatal steroids in most of these babies, and now we are also using postnatal steroids in many of these babies to decrease the progression of BPD. So we always have to keep in mind that steroids are a double-edged sword that can, on one side, improve lung function, decreasing inflammation, but on the other, can also aggravate the impairment in alveolarization. So going into the clinical factors, you can see that they relate very much to the factors that have been shown in experimental animals to interfere with alveolarization. Low gestational age, growth retardation interfere with lung development. Males and white race are also associated with more alteration or higher risk of BPD. Maternal hypertension has been shown also by many to interfere with lung development and increase the risk of BPD. Infections, as we mentioned, chorioamnionitis and colonization with uroplasma are also clinical factors that increase the risk of bronchopulmonary dysplasia. And then maternal smoking or vitamin D deficiency can also increase the risk of BPD. Postnatally, as I mentioned from the beginning, severe RDS with aggressive respiratory support, clearly associated with higher risk of BPD. Postnatal infections also, we have shown that increase the risk of bronchopulmonary dysplasia, same way as a prolonged patent ductus arteriosus with pulmonary overflow. Early pulmonary hypertension is also a factor that has been associated with increased BPD, and as prenatally, also postnatal nutritional deficiencies can also increase the risk of bronchopulmonary dysplasia. So you can see that clearly BPD is a multifactorial consequence of prematurity and a number of other antenatal and postnatal factors that interfere with lung development and lung function. So if we talk about prevention, we cannot expect a magic bullet. We will have to remember always all these many factors, and I'm sure there are many others that have to be addressed if we want to have any influence on the incidence of BPD. So let's review briefly the evidence. Infection, as I mentioned, antenatal or postnatal is associated with higher risk of BPD. This is work from Alan Jobe showing that the injection of the endotoxin in premature lambs produces an inhibition of alveolarization, showing then smaller number and larger alveoli when compared with the controls in the upper portion of this slide. You can see in the lower portion that beta-metasone exposure of this fetal sheep also produces inhibition of alveolarization. This graph shows the relationship between chorioamnionitis and bronchopulmonary dysplasia, and you can see that most of the studies published in the literature show also a relationship between chorio, maternal infection, and increased risk of bronchopulmonary dysplasia, something similar with uroplasma colonization. Uroplasma colonization occurs very frequently in extreme preterm infants. Up to 50 or 60% of these babies may be colonized with uroplasma. And you can see here also that most of the recent studies where they have analyzed the possible relationship between uroplasma colonization and BPD show a very striking correlation. we say higher risk in those babies who are colonized. Many of these babies, or most of these babies, are intubated at one point or another. So we were interested also in finding out what was the relationship between intubation, colonization, and BPD. And as you can see in this data from our institution, colonization with gram-negative, gram-positive, or postnatal sepsis are also related with a higher risk of bronchopulmonary dysplasia and with BPD or death. Now, when you look at this, you say, well, maybe we should be culturing all these babies and treating this colonization. Unfortunately, there is a good amount of evidence from several publications showing that the use of antibiotics during the first few days of life in babies who are not clearly septic can increase the risk of BPD and also can increase the risk of NEC. Here you can see the increased odds ratios of BPD in relation to the administration of antibiotics for more than 2 days during the first week of life in babies. So unfortunately, in this situation, what we have to do is to try to prevent colonization of intubated babies, something that is not easy to achieve, but we have to be very careful not to use antibiotics when they are not indicated for other conditions. Positive mechanical ventilation with positive pressure ventilation then is the other mechanism that can produce lung injury. And here there is plenty of animal data showing that overdistension of the lung with high peak inspiratory pressures and large tidal volumes can induce inflammation and can also alter alveolarization. In terms of clinical data, this is from the Italian network, showing a clear relationship between the proportion of babies intubated at birth in the delivery room and the incidence of BPD. And doing logistic regression analysis, this group of investigators in Italy showed that more than 7 days of mechanical ventilation was associated with a risk of BPD that was almost 15 times higher than babies that were ventilated for shorter period of time. So I think that from the very beginning, when BPD was described, there was pretty compelling evidence that the use of mechanical ventilation was clearly associated with BPD. And that's why neonatologists have been very interested in trying to minimize the use of aggressive mechanical ventilation by using less invasive modes of respiratory support. And the most used non-invasive mode of respiratory support is CPAP, continuous positive airway pressure. And there were many studies where patients were randomly assigned to a group of patients who were intubated and ventilated and got surfactant, and another group who got only CPAP. You can see that all the studies showed a reduction in death or BPD, but none of them reached alone significance. It's only when you analyze all this data together that you find that the use of CPAP during the first hours of life, instead of intubation and mechanical ventilation, can reduce the incidence of death or BPD. But you can see also in this meta-analysis that the effect is relatively small. In fact, it barely reaches significance. Now, why is this? This may be in part because babies who are not intubated or were not intubated in these studies did not receive surfactant, and therefore they may have developed more severe RDS and they may have missed the benefit of postnatal surfactant. And that's why many investigators, mainly in the European countries, suggested the use of intubation, administration of surfactant, and immediate extubation as a way of providing the benefit of surfactant and limiting the damage induced by intubation and mechanical ventilation. This mode of respiratory support is known as Ensure. And you can see here that using Ensure versus conventional intubation and ventilation, these studies have shown a reduction in the need of mechanical ventilation, reduction in Ehrlich syndrome, and also a significant reduction in bronchopulmonary dysplasia. Mortality was also lower in the babies that were treated with Ensure, but here there was no, this data did not reach significance. The other problem, besides the lack of use of surfactant when you are using non-invasive respiratory support, is the fact that the smaller babies who have the higher risk for BPD are the ones that more commonly fail nasal CPAP. Here you can see this data from Australia, where babies, as they reduce the gestational age, have a larger proportion of infants who fail nasal CPAP. This is shown in the black portions of these bars. So here we are facing a situation where the smaller babies who have more severe RDS, who have the highest risk for BPD, unfortunately, frequently do not do well just with non-invasive ventilation. This is mainly because of poor respiratory control, and it's also related to the fact that they have poor respiratory muscle activity, a very weak thoracic wall, and therefore, finally, sooner or later, they need intubation and they need ventilation. This is because many clinicians today have proposed the use of non-invasive ventilation that will be discussed in another talk this morning as a way of still avoiding intubation and ventilation and trying to support these babies a little bit more aggressively. So we have to say at least a few words about what types of mechanical ventilation can we use in these babies who fail nasal CPAP or nasal ventilation and still need intubation and invasive ventilation. And the modalities that have been shown to reduce the risk of BPD are patient-triggered ventilation and volume-targeted ventilation. Synchronized ventilation and volume-targeted ventilation, both of them reduce the duration of ventilation, and most likely because of that, reduce also the incidence of BPD. This is the effect of volume-targeted ventilation on duration of ventilation. You can see that these babies come off mechanical ventilation sooner, and also there is data showing that volume-targeted ventilation reduces the risk of death or bronchopulmonary dysplasia. Unfortunately, volume-targeted ventilation is a strategy that is not easy to apply, so there are many centers where this strategy is not used routinely, including our unit, and we can discuss this, the reasons for this in more detail during the discussion period. High-frequency ventilation is probably the modality that has been investigated in more studies during the last 20 or 30 years as a way of reducing BPD. The original studies done in the 90s suggested, many of them, that the use of high-frequency ventilation could be associated with a lower risk of BPD or death. As the time went by, you can see that the results, when studies compared high-frequency versus conventional ventilation, they did not show, and they have not shown, a significant improvement in terms of less BPD. Why is this? I think that this trend doesn't mean that high frequency is worse now than what it was in the 90s. I think that this data suggests that what is happening is that we are better prepared now to use invasive conventional ventilation and reduce barotrauma by monitoring tidal volumes, by avoiding over-distension more effectively. The other factor during mechanical ventilation that is also damaging to the lung and that interferes with alveolarization is oxidative damage. And because of that, there has been a constant effort to try to minimize the duration and the amount of oxygen that we are giving to these babies. And you know that during the last 15 years, there were several trials done to try to compare high versus low oxygen targets. Fortunately, all the studies used a very similar protocol, so they could be analyzed together in meta-analysis. And The low target was 85 to 89. The high target was 91 to 95% saturation measured by pulse oximetry. Here in this meta-analysis from Dr. Askey in Australia, you can see that the incidence of bronchopulmonary dysplasia defined as oxygen at 36 weeks was lower in most of the trials in those babies who were ventilated with a lower oxygen target, 85 to 89. So essentially this confirmed the fact that if we use lower oxygen concentrations, we may reduce the incidence of BPD. The problem with this data is first that the effect is relatively small. And in fact, 2 of the studies did not show any benefit of the low target. And the other bigger problem is that in these trials, as you all know, it was shown that the lower oxygen saturation target, 85 to 89%, was associated with a higher incidence of death before discharge. So obviously the price of using a low target, although may have some benefits in terms of reduced BPD and reduced ROP, it may be associated, or it seems to be associated with a higher incidence of bronchopulmonary, with death in the small babies, and therefore this is a strategy that cannot be recommended as a prevention for BPD. This doesn't mean that we're going to use any oxygen concentration or any target. Obviously, the idea is to try to give the least amount of oxygen, but maintaining saturations over 90% to avoid the possible detrimental effects of hypoxia. So the introduction of all these strategies that we have discussed until now were effective in changing the BPD presentation. What is interesting is that the severe BPD, so the classic forms of BPD, were reduced during this period of time from around 25, 28% to less than half, about 6 to 8%. But total BPD, including the mild forms of bronchopulmonary dysplasia, has not changed much. And I think that this is a very nice indication of what really happened with the presentation of BPD. Severe BPD, shown in the white bars, was the BPD, the classic BPD that was mainly related to injury induced by mechanical ventilation, oxygen in high concentrations, and infection. The mild BPD is the derangement of alveolarization that is really more related to prematurity than to any of these other factors. And therefore, as long as we have small premature infants surviving, will be very difficult to eliminate this alteration in alveolarization and these milder forms of BPD. So what we have done essentially is what I showed before. We have changed this form of original severe BPD for a milder form that is very common in the smaller babies. So the classic BPD was reduced by the use of antenatal steroids and surfactant that minimize the severity of RDS, and also has been reduced substantially by using mechanical ventilation in a more careful way, and also by controlling or reducing the incidence of infections, antenatal and postnatal. The challenge now is these milder forms of BPD. That is what I'm going to discuss in the few minutes that I have left. The first topic that has to be mentioned, or the same problem that has to be mentioned, is PDA. We showed in 96 already that the presence of a patent ductus arteriosus, especially when this PDA was associated with postnatal infections, this led to a striking increase in the incidence of bronchopulmonary dysplasia. I'm not going to say anything more about this because Dr. McNamara made this point very clearly. There is a lot of data showing that the presence of a PDA, especially a large left to right shunt with pulmonary overflow, is associated with lung disease and more BPD. But until this day, we still don't have a clear way of selecting those patients that require early PDA ligation to improve outcome. The other strategy that I want to mention briefly is caffeine. This is the data from the CAP trial from Dr. Schmidt many years ago, who showed that the use of caffeine in preterm infants reduced the incidence of bronchopulmonary dysplasia versus the group of infants who received placebo, 36 versus 46%. And also she showed that there was a lower incidence of PDA in those babies who received caffeine. Since this time, there have been a number of studies that have analyzed the use of early caffeine as early as in the delivery room in some studies as a way of improving respiratory outcome. This was the first set of analysis that was done in the same CAP trial by Dr. Peter Davis in Australia, who showed that when these babies received caffeine earlier, they had less mortality, less cerebral palsy, and they also had less BPD than when the caffeine was given later. This has led to a change in the management strategy of these babies. And as I mentioned, many units today are using caffeine very early from the first day of life. I think we have to be careful because the data that suggests that early caffeine is beneficial or may be beneficial is retrospective, not from prospective randomized trials, and is not consistent. This is a study with a huge number of patients published by Dr. Ravi in Atlanta, showing essentially that there was no difference in outcomes between those babies who received early or routine caffeine administration. No difference in NEC, no difference in BPD, 11 versus 13%. The only prospective randomized trial to evaluate if early caffeine is beneficial was done in our institution, and this was published 2 years ago in Journal of Pediatrics. This is a relatively small study that was really with the intention of only being a pilot investigation, and we then randomly assign patients to early caffeine during the first 3 days of life or control only caffeine prior to extubation. And you can see here that in this trial, we did not see any effect on BPD, 30% versus 32%, or BPD or death, 56 and 57%. So in our judgment, the caffeine question is still open. We clearly need larger and more prospective randomized trials before we decide that every baby will be treated with caffeine from the first day of life. Again, I want to assure that you are not getting the message that I am saying that caffeine is not beneficial. Caffeine is very beneficial to reduce apnea and to improve extubation success. What we are not sure is that caffeine should be used prophylactically in babies who are being ventilated. We don't think that the evidence for that population is clear. The last few minutes, let me say a few things about future strategies that may reduce the incidence of BPD, and these are mainly related to the use of anti-inflammatories, because as you can see in this diagram, cytokines is at the center of the pathogenesis of bronchopulmonary dysplasia. All the factors or the main factors that produce an increase in the risk of BPD are mediated through cytokines that alter many of the molecules that are key in the development of the lung. So by using modulators of inflammation, it is possible to reduce the incidence of BPD. Postnatal steroids clearly have been shown to reduce death and reduce bronchopulmonary dysplasia, but unfortunately, as many other interventions in neonatology, they are also associated with a number of side effects, hypertension, cardiomyopathy, and the most important, there are many studies that have shown that postnatal steroids in large doses and for long periods of time can increase the risk of cerebral palsy. And it's because of that that people have used different strategies, or they have attempted different strategies to control inflammation and try to reduce the side effects. One of those strategies has been hydrocortisone administered during the first 10 days of life. And here you can see that survival without BPD was improved in babies that received hydrocortisone versus placebo. But once again, these studies showed side effects of hydrocortisone. In this case specifically, there was a significant increase in GI perforation. So this, in our judgment, is a strategy that cannot be recommended routinely. One of the uses of steroids that may improve outcome with relatively small side effects is the combination of surfactant and budesonide, a strategy that was reported by Dr. Ye, working in Chicago and in Taiwan. And the advantage of this strategy is that the babies get only 1 or 2 doses of the budesonide with the surfactant when they need surfactant for their RDS. He showed a significant reduction in BPD or death. Death did not change, although it was lower in the babies who got also budesonide, not significantly different. In severe BPD, you can see that was reduced from 19 to 9% in the babies who get the surfactant with the budesonide. So this is clearly a promising strategy, promising not only because of the positive effects on lung function and lower BPD, but also Dr. Ye evaluated a subgroup of these patients in terms of their long-term neurodevelopmental outcomes, and he showed no evidence of negative effects in the babies who received the budesonide. There are many studies now ongoing in different parts of the world testing this intervention. So I think we will have to wait a few months or years until results from other trials come out so we can confirm or we can accept this strategy as effective and safe. So looking into the future, there are a few interventions that are also being investigated and that may also be beneficial through the same mechanism of mediating inflammation. And one of them is the administration of stem cells. This is a study done in our unit by the group of Dr. Shu Wu and Karen Yang, where using a rat model of BPD by giving oxygen, they show that the exposure of oxygen with placebo, you can see produces a decreased number of alveoli, much larger, indicating decreased alveolarization. When they used another group of animals that were exposed to oxygen, but that received mesenchymal stem cells, you can see that the alveolarization is significantly improved with a better alveolo-capillary surface. This intervention with administration of mesenchymal stem cell has been used in many other groups, but the only human study that has been reported until now was a phase 1 study done in South Korea by Dr. Chang and collaborators. And they did not, this was not a prospective randomized trial. They just gave mesenchymal stem cells into the trachea to a group of infants with severe RDS. And they showed that this group, when compared with a historic control group, had a better respiratory outcome. The respiratory severity score came down after the administration of the stem cells, and they also showed a decreased inflammatory marker concentrations in the trachea. Again, this is a very interesting alternative, but we have to wait until there is further evidence. This study was published in 2014, and until now, I am not aware of any other data showing that the use of stem cells, again, is effective and safe. So to finish, is BPD preventable? I think that there is no question that BPD cannot be prevented in the smaller babies. What we have to aim is to try to reduce the severity of BPD. And as we have discussed throughout these 45 minutes, BPD is a multifactorial complication of prematurity, and therefore we have to address many different mechanisms that interfere with alveolar simplification. So I am convinced that we can have an impact, and this is shown by the tremendous differences between different institutions in the world, and also by the reduction in the incidence of BPD in many units that have applied packages of intervention, all aimed at reducing the factors that produce lung injury. So this is just a list of the established interventions that I have already mentioned, most of them: less invasive ventilation, volume targeted and synchronized ventilation, caffeine for extubation and apnea, vitamin A, and postnatal steroids. These are all, again, therapies that have been shown to reduce BPD without significant complications. On the right, we have data on trials that are ongoing: mesenchymal stem cells, surfactant and betamethasone, early PDA closure, IGF. There is a large multi-center trial going on also, trying to test whether IGF administration can reduce BPD, azithromycin in babies who are colonized with uroplasma. There are also trials going on now, funded by NIH, to try to see if this can reduce BPD. And I think that something that has to be investigated is human milk. There is retrospective data showing that babies fed with human breast milk have a lower incidence of BPD than babies receiving formulas. But again, these are retrospective analysis, so there are many confounders that the only way of eliminating them will be to do good prospective randomized trials. Just to finish, this is the data from our institution in the last few years. You can see here babies of different gestational age. The total is the black line, and we clearly have seen a steady reduction in the incidence of especially severe BPD from around 18% to a very low percentages in the last data that we have in 2018. So we are optimistic. We think that BPD can be reduced, can be minimized. And I think that even if the baby still has BPD, one of our goals should be to reduce the severity of the lung damage. And all the interventions that I have described, they don't only reduce the total incidence, but they clearly make the damage, pulmonary damage, less severe. So thank you very much, and I will be happy to answer questions later in the discussion period. Thank you.
Okay, thank you, Dr. Ben-Kalari. I think over to you, Tawfiq. We will have a question answer session in the end of the seminar. Okay, so because Dr. Ben-Kalari can come, will be back.
Yes. So thank you very much, Dr. Banklari. So now I request Dr. Rajiv to give introduction to Dr. Vineet Bhandari.
Hello. Hello. Can you hear me?
Yes, Doctor.
I would like to welcome my colleague, Dr. Vineet Bhandari. He's actually part of my textbook, and we both wrote the chapter on BPD. But I have to say a few words about him because it is my duty to introduce him in a proper manner and not as a friend. So he has passed from Armed Forces Medical College, Pune, which is a premier institute of India, and later did his post-graduation in PGI Chandigarh, one of the pioneering institutions in India for neonatal programs. Subsequently, he became the head of department in Albert Einstein Medical Center, and later he became chief neonatal perinatal medicine St. Christopher Hospital for Children, and has got the latest appointment is at division head of neonatology at Children's Regional Hospital at Cooper in 2020. He has published a lot of books, and out of it, 3 of his books are very impressive. He has a book, a Manual of Neonatology, and I really loved his book on bronchopulmonary dysplasia. And he's the author of another textbook which I found very interesting, is Tantalizing Therapeutics in Bronchopulmonary Dysplasia. He's authored almost 300 chapters, and I was very happy to have him as my main editor for my chapter on BPD in my textbook. So I now give the mic to my Dr. Vineet. So Vineet, please entertain us and enlighten us with tantalizing lecture.
Thank you, Rajiv. I will be able to hopefully thank you, Rajiv, for the introduction and for the kind invitation to speak in this symposium. It's a very nicely organized, and it's so great to see Dr. Sagar and Eduardo and Daniel and everybody will be, Daniel will be speaking after me in about 45 minutes or so. So let me see, I will see if I can get my slides up to share. Tawfiq, can you?
Not yet.
Not yet. Okay, let me first, I think, let me go back 1 second. And then I think share my slide that way. Share screen, go here.
Yes.
All right, can you now see my full screen?
Yes, Doctor. Now we can.
Okay, all right, great. Thank you so much. And so today I'm going to be trying to talk about ventilator management to prevent and treat bronchopulmonary dysplasia. And I'm going to try to make it very practical and give you very specific suggestions of how we manage babies. And obviously we will have time for questions at the end the discussion section. One of the things that has been a problem and continues to be a conundrum, clinical conundrum, is the definition of BPD. But for the sake of this talk and for most practical purposes, I'll be using this definition, which is a clinical definition using therapy as a marker or as a diagnosis for BPD. And for the babies less than 32 weeks, we make an assessment at around 36 weeks post-menstrual age. If the baby's been taking, being exposed to supplemental oxygen more than 21% for at least 28 days, plus at the assessment time of 36 weeks, if his baby is breathing room air, then it's mild BPD. Less than 30% oxygen is moderate, and severe if the baby requires more than or equal to 30% oxygen or any kind of positive pressure ventilation support, whether it is invasive or non-invasive. Let me see, now it seems to have not moving the slide.
The slide is not moving, Doctor.
There we are. Okay. So the pathogenesis, this is a simplified version of the pathogenesis. You heard Eduardo give you a little bit of information about this, but I want to highlight a couple of things. One, that it is a combination of genetic and environmental factors. And genetic factors probably contribute somewhere between 50 to 70, 80% of the risk to BPD. But the three major environmental factors is going to be ventilator trauma, specifically invasive ventilator trauma, infection, which can be prenatal or postnatal, and exposure to high concentration of oxygen. So when you have these combination of genetic and environmental factors acting on a foundation of an immature lung. Notice the fact that I put a plus minus sign in front of surfactant deficiency. And this is very important because you do not need to have surfactant deficiency or RDS to get BPD. It is the immaturity of the lung, it being in the late canalicular and early saccular stages, that really makes a baby get into what is now called new BPD. And I'll show you a little bit of a more detailed slide in the next one. So essentially these factors acting on an immature lung leads to inflammation and that leads to cell death. And then you land up with a situation where the lung will try to heal itself and resolve the injury. It could be because of environment, it could be like stem cells, nutritional factors, there are lots of other factors that could be playing a role here. And if you're able to do that, and luckily the lung grows, then you may get a reasonably normal lung as you grow older. However, if the lung gets so severely damaged and the reparative process is not is put into play, then you land up with a situation of impaired alveolar development and dysregulated. This is very important to realize that it is not decreased, but dysregulated vascular development, where there are areas of decreased vascularization as well as increased vascularization, which leads to an impairment of blood gas exchange. And that is your classic pathological feature of BPD. So to give a little bit more detail of what we now call new BPD, you have a list of prenatal factors here. Eduardo mentioned pregnancy-induced hypertension, hypoxia, infection, smoking is an important factor, antenatal steroid, lack of antenatal steroids, and other factors, as well as we will talk a little bit more detail about how we decrease invasive mechanical ventilation in an effort to decrease these forms of biotrauma, which hopefully will also decrease these inflammatory cytokines. And hyperoxia plays a very important role in the pathogenesis of new BPD because of DNA damage, lipid peroxidation, and protein oxidation, again, releasing multiple inflammatory markers and factors, which leads to aberrant tissue repair and which inhibits vascular and alveolar development and leads to BPD. So to summarize, at least in terms of the pathogenesis, it's a combination of maternal factors, infant predisposition, that is the genetic susceptibility due to a variety of reasons, including the microbiome, which we have recently shown is an important player in the pathogenesis of BPD, mechanical ventilation, which is going to be the focus of the talk, and oxygen injury. So the classification of BPD, the older classification, or one of the standard classification that people have used, is 4 stages of BPD. And I'm just going to show you some X-ray images of the 4 stages. But I will then go to what I like to call a more practical way of looking at BPD and planning your management strategies based on that classification. So this is a stage 1 of BPD, where you essentially it's indistinguishable from respiratory distress syndrome. You see small lung volumes, reticulogranular pattern, air bronchograms, and it's just like a baby with RDS. It moves to stage 2, where it's around, I would say around the first week of life, day 5 to 7, where you have homogeneous opacification of lung, there's increased edema, and some increased interstitial markings with coarse confluent densities. Stage 3 is more, you will start seeing some opening up of loosened vacuoles here, appearing as air cysts, just showing you how damage has been occurring to the lung, and the body is trying to heal, but it actually goes into the repairing phase rather than the healing phase. And then you land up with stage 4 BPD, which has this bubbly cystic appearance of the lung, as you see very nicely here in the left upper lobe. And then you have this strands and streaks in the lower zone showing you decreased lung volumes and obviously a severe impairment of blood gas exchange, as obvious from the fact that this baby had the endotracheal tube and is being ventilated. So how do we start managing the ventilator management? And I think it is important to remember that obviously antenatally it'll be great we give steroids, antenatal steroid. That is probably the most important antenatal intervention one can do to try and make an effect, at least in trying to decrease the severity of lung injury or severity of lung disease right at birth. Though it has not really been shown to make an impact on BPD, but I still believe it is very important to get your MFM, maternal fetal medicine, and obstetric colleagues to remember to give the baby antenatal steroid, and preferably if they can delay the delivery for about 48 hours. So once you are born, what would be the next steps? Now, there was some hope that sustained lung inflation would maybe be helpful in the delivery room, but right now, based on the latest data, especially from the SAIL trial, there is no evidence to support the use of sustained lung inflation. So at least in the next edition of this chapter, this will get removed. Then the issue comes up, how do we manage this baby? And I think there's a lot of data to suggest that if you do not need to intubate and ventilate the baby, it would be great to avoid that. So you could do that by using CPAP, which is the more common method, or you could use nasal intermittent positive pressure ventilation, which I will talk about at the end of the talk. But however, it is also important to remember, as Eduardo also emphasized, that if a baby requires surfactant, you should give it, and you should give it early, which means preferably in the first 2 hours of life. Most of us, at least on our unit, we tend to use Ensure, which is intubate surfactant, and basically then extubate the baby quickly. And then when we extubate the baby to nasal IPPV. I don't have the synchronized machines anymore, so I don't have SNP, but I do have NIPPV, and that is pretty much standard of care And in the Cochrane review has also shown that if you extubate a baby, if you needed to intubate the baby earlier on to nasal ventilation, you would probably get a better outcome in terms of their risk, decreasing the risk of intubation failure. Now, if they do require intubation, one should obviously try the best to minimize the amount of atelectotrauma, barotrauma, and volutrauma, as I will talk about in a few minutes. And then we will hope that these babies will, if you cannot prevent BPD, at least we'll try to get a less severe version of BPD. The important point of this slide is that an effort to prevent / decrease the severity of BPD should start from birth itself, because the first few days of life is very critical in how the process of inflammation develops and how you can try and prevent and treat BPD. These are some of the modes of ventilation. It's one of the slides that I used to teach my residents and fellows. You can see here, IMV stands for intermittent mandatory ventilation. SIMV is synchronized, assist control, and pressure support. And we do believe that if you are going to be using some type of pressure support or pressure control, try to use pressure support and use synchronized ventilation as giving the baby help and the baby is trying to breathe himself or herself. We do believe that it seems to decrease the degree of injury. We routinely now actually use volume targeted ventilation. And so in most babies, if we have to intubate and invasively ventilate the babies, we will go for volume targeted ventilation first. If that's not working out for the baby, then we will move to SIMV or pressure control, pressure support ventilation. So how do we manage a baby when in terms of their blood gases? And this is one of the attempts to see what happens, what you can do to improve oxygenation. So there's a variety of techniques you can improve oxygenation. You could increase PEEP. Now, again, it depends on how much PEEP you have started off with. We normally start off with PEEPs of around 5 to 6 centimeters of water pressure, and we will increase up and to about 7 or 8. There are institutions that like to go up higher, but we are a little bit more shy of going higher than 8. Especially in the smaller babies, I usually rarely go above 7 because I'm concerned about the risk of air leaks. One could increase the peak inspiratory pressure or increase the inspiratory time, but if you do increase one or both of these, remember you're going to be increase your mean airway pressure, and so you have to be careful that you do not exceed 12 in the smaller babies, 12 centimeters of water pressure, mean airway pressure, because that might also increase your risk of developing air leaks. We could increase the rate, and that does not really improve the oxygenation that much. So it's not really helpful. So the first top 3 would be the most important ways of increasing oxygenation. Increasing FiO2, a fraction of inspired oxygen, obviously will increase the amount of oxygen you're delivering to the baby, but you have to be careful because oxygen is a drug like any other drug and would have certain specific side effects in terms of oxidative damage. I tend to use the 40, 60, 80% rule, and there is data from humans as well as from the animal studies that these values probably should help you guide what oxygen exposure you should be given to the premature baby. If you are between room air and 40%, you're pretty much creating the same degree of damage in terms of the oxidative damage. Similarly, if you exceed 60 or you go beyond 80, if you're at 80 or 100%, it really doesn't make that much of a difference in terms of the degree of oxidative damage that you'll be giving to the baby. So once I reach the numbers 40, 60, or 80, I try to decrease the FiO2 requirement, again, maintaining oxygen saturation at a specific target, which I will also talk about, by increasing either the mean airway pressure through the top 3 mechanisms, either increasing PEEP, PIP, or I time. My effort has always been to try to keep the baby's FiO2 to 40% or less, at the same time trying to keep the mean airway pressure at 12 or less. And again, if I could extubate the baby, that would obviously would be the ideal situation. How do we improve ventilation? By that, I mean, how do we wash out the CO2? We could increase the rate. We can increase the tidal volume, which, as I mentioned to you, is what we tend to use as our first line of invasive ventilation in the smaller babies. And we usually target a tidal volume of 4 to 6 ml per kilogram in the first few days of life. You can increase the PIP or decrease the PEEP to improve your ventilation by increasing the difference between the PIP and PEEP, which will help you wash out more CO2, or you could also increase the inspiratory time. The important thing when you're messing around with the I time is that you try to remember to keep the I to E ratio as much as 2:1 as possible, or 1:2 to be more precise. You want the expiratory time to be at least twice as long as the inspiratory time, because if you keep increasing your I time and you do not give enough time for the baby to breathe out the CO2, you can then land up with air trapping and inadvertent PEEP development. So always keep in mind, if you do go up on the I time to beyond 0.5, 0.5, 0.5, 0.55, or 0.6, you are going to be shortening your E time, and that may not be an ideal situation. So keeping the ratio, I to E ratio of 1 to 2 is probably the most physiological way of handling the I to E time ratio. Here are a couple of suggestions of how you make adjustments on your ventilators based on blood gas analysis. Most of this is instinctive, and most of you hopefully are aware of how to manage it. But again, the point over here is that if you're dealing with a situation, for example, hypoxia and hypercarbia, you can increase your peak airway pressure till you reach a certain level of mean airway pressure, and try to keep it as less than 12 as much as possible. In smaller babies, just increasing the rate might also work for these two blood gases abnormalities. And similarly, so on and so forth. Obviously, if you have a low PaO2, you go up, increasing the mean air pressure of FiO2. But once again, I would recommend that you focus on the 40, 60, 80% rule, in the sense that you try to keep the FiO2 less than 40, less than 60, less than 80, by compromising in terms of increasing the mean air pressure, and vice versa, to try to keep the degree of damage that you're creating in these babies with invasive ventilation. And as you go down the algorithm over here, you can see that depending upon where you are, you may have to sometimes sit tight unless you are ready to wean the baby. And when you are weaning the baby, obviously the effort is to try and get the baby to non-invasive support. And as your first choice of non-invasive support, I would highly recommend you use NIPPV, and I will talk about that at the end of this talk. So I mentioned to you that I don't usually like to look at BPD in terms of stage 1 to 4, because I don't find them very practical. So what I tend to do is I tend to describe BPD in 3 phases, which I find very in a practical way. I call it the early, evolving, and the established phase. The early phase is essentially the phase is from birth to 1 week of life. Evolving phase is from 1 week of life to about 36 postmenstrual age. And established phase is when you have beyond 36 weeks postmenstrual age. And these are the approximate values of ventilator settings, invasive ventilation settings that we are trying to use. And you can see over here in the early phase, we try to keep the I time somewhere around 0.3, 0.35, and then we increase it slightly in the evolving phase. And if necessary, we'll go on to the established phase, we'll increase the I time even higher. I will talk about severe BPD to some extent, and Daniel will talk about it in more detail in the next talk. And I'll give you some strategies of how we handle established/severe BPD too. The tidal volume, initially, we would probably start around 4 ml per kilogram, and we do increase it slightly as you go up. Again, severe BPD is a separate category, and we will talk about that in more detail later. The PEEP I tend to use, like I mentioned to you, I rarely go above 7, even in the evolving phase, because of the worry I have of air leak syndromes. For pressure support, these are the pressure support values we use, and this gives you some idea, depending upon the size of the baby, what pressure support values are recommended to try and minimize the degree of injury to the lung. The blood gas target. So in the early phase, I'm very happy if the baby has a blood pH of 7.25. I have no issues in trying to push the ventilator further, and I try to keep the PaO2 between 40 to 60. 45, 50 is fine, and PCO2, this is PaCO2. So if you're doing capillary blood gases, please add anywhere between 5 to up to 10 millimeters of mercury higher values to this. So it would be somewhere in the 60, 65 range should also be okay, as long as the blood pH is okay. So let me give you a bit of a strategy of how we handle babies who are around 23 to 26 weeks of gestation. So initially, we will start the baby from the delivery room on CPAP around 5 to 6. Sometimes we also do NIPPV by using the T-piece. And if the baby is requiring more than 35% oxygen, we will actually intubate and give surfactant, and we extubate to NIPPV. Once we extubate to NIPPV, we will try to keep the baby extubated. And we hope if we keep the baby extubated and keep the oxygen requirement somewhat less than 30% or 35%, we may be avoiding BPD, or at least we can probably get into a stage of mild BPD. if the baby requires to be reintubated because of apnea or because of atelectasis of the lung, then again we focus on volume guarantee ventilation and try to prevent the mean airway pressure from going higher than 12. If the baby's mean airway pressure goes higher than 12, then we tend to use rescue. We use high frequency oscillator ventilation. We also have the jet in our unit. So depending upon if the ventilation is a problem, we will first usually focus on high oscillatory ventilation. If oxygenation is a problem, and despite high frequency oscillation, then we might switch the baby to high frequency jet ventilation. But usually if the baby is still requiring high pressures and oxygen at 7 days of life, and especially if the baby has a hemodynamically significant PDA, we probably will not be able to avoid diagnosis of severe BPD. The effort, like always, is to try to extubate the baby to non-invasive ventilation. And when we extubate the baby, we go to NIPPV. So the PIP the setting that we use to extubate a baby will be 16/5, rate around 15 to 25 per minute, and NIFI out around 30.35. So once the baby reaches this setting, we will make an attempt to extubate the baby. Now, in the evolving phase of BPD, this becomes more of a challenge because the baby has been intubated or and not been able to extubate. And again, we try to make an effort of how we can optimize the management of these small babies. And again, we are worried about if we can keep the baby extubated, that would be great, because I think if we can keep the baby extubated beyond a week of life, even if it's like a 10 days of life or 14 days of life, I think we still have a good chance of the child getting mild BPD. However, if the baby gets into problems with infection or the PDA becomes a problem, then you may have to go higher levels of mean airway pressure, going back and forth between oscillatory ventilation and either SIMV mode or volume guarantee ventilation. And then if that happens, you might land up with moderate to severe BPD during this phase. I tend to keep about the same pH targets in terms of the blood gases. And you can see over here the PaO2 and PaCO2, I'm allowing the CO2 to be climbing up a little bit more. In the established phase, which is obviously very challenging, and we are dealing with most situations that the baby is going to get moderate or severe BPD. And once again, the effort is to try and get the baby extubated, but if you're not, we tend to use SIMV mode. And then of course, we are also dealing with BPD spells and pulmonary hypertension. I won't talk much about pulmonary hypertension because that's a lecture by itself, but I will talk a little bit more about how we do management of severe BPD to some extent. The blood gas targets is about, as you see over here, allow a higher amount of PaO2. This is an effort to try and decrease, or at least try to decrease the severity of pulmonary hypertension that these babies are prone to, because oxygen is actually a much stronger vasodilator than even nitric oxide. So trying to keep the PaO2 high and the targets of saturation also higher at this point. Let me talk a few words about BPD. You will hear a lot more about it in the next talk, but this is just to showing you a picture of the cystic lungs, and you can see this is really bad lungs of a baby, has bilateral cystic changes, and would be considered to be called severe BPD. And the problem with severe BPD is that it's a heterogeneous disease, because there are certain areas where the lung is overexpanded and certain areas the lung is atelectatic. And so it becomes a real challenge to try and ventilate these babies. And so here to give you an illustration of what I'm talking about. So here you have a situation where you have normal compliance or normal resistance, and there's certain parts of the lung that have high compliance, certain parts of the lung have high resistance. As you can see here, there's not enough gas exchange can happen because you're not able to even ventilate this parts of the lung. And so you get into land up in a situation where you have worse distribution of gas, increased dead space ventilation, and higher PCO2s and higher FiO2s. And so to try and get rid of this problem, or at least try and ventilate these kind of lungs, we will try to have to use higher tidal volumes and longer inspiratory times. And some of the numbers that you're going to see may say, oh, that's a very, very high number for a small baby. But remember, these babies are usually beyond 36 weeks of post-menstrual age. And because of the lung disease being so severe and the lungs being so stiff, that you really will need these kind of settings to really be able to ventilate it. So for severe BPD, we will use PEEPs of 6 to 12, and I've gone up as high as 15 centimeters for some of the really bigger babies. Our tidal volumes are 8 to 12 ml per kilo. Almost invariably, I am somewhere between 0.5 to 0.6 seconds of the eye time again. There is this problem of the CO2, which may not have enough time to be removed, but we hope that at least with the higher PEEPs, we will be able to wash out the CO2 and we give higher values of the pressure support numbers. So as I mentioned to you, there are two characteristic phenotype of babies with severe BPD. One characteristic is a baby where there is atelectatic variety, and the one that is overexpanded or hyperexpanded variety. So in this one, you have atelectasis, and here usually we land up with more of an oxygenation issue. And so to try and counteract the oxygenation problem, we have to use higher PEEPs. And look at the number that I'm quoting here. It will start around 6 to 8, but I will go up as high as 12 and sometimes even as 15 to try and get the oxygenation done in this child. Let me just go back for a second here. And tidal volumes around 4 to 7 ml per kilo. On the other hand, you're dealing with a baby which is overly cystic or overly distended alveoli. It's more of a ventilation issue. So we tend to go lower on the PEEPs, and we keep the higher tidal volumes to try and wash out the CO2, and allowing the CO2 to be as high as 65 mmHg PA CO2, as long as the pH is at least 7.25 and above. So to give you an idea, for in a situation in the atelectatic variety, we will use a tidal volume of 4 to 7, but we'll go up higher if it's required. And if it's of the other variety, then it's going to be mostly on the acting mostly on the tidal volume. So this, let me give you some examples of how we have managed these kind of babies. For example, here you see a baby on the SIMV mode settings of 26/11 and pressure support of 13, rate of 40. And you see the oxygen requirement of this baby is almost 100% here. And what we have done in this baby is we have increased. We can see the lung is collapsed, there's atelectasis and smaller lung volumes. And what we have done is we have increased the PIP from 26 to 30, increased the PEP from 11 to 12, and increased the pressure support. And then we are able to decrease the FiO2 from 90% to about 87%. And the lung seems to be a little bit more open, and definitely we had better gases. This is, as you see, with the baby is improving. But this is another example where we have 26/10, we went up to 26/11. So just an increase of one value on the PEEP was able to open up the lungs quite nicely, and we were able to get the FiO2 down from 95% to about 78%. In the ones that we are dealing with the ventilation problem, we will need to use higher tidal volumes, and these are the numbers that we usually go for. And let me give you an example over here. You have a baby on 25/5, rate of 45, tidal volume of 3.5, and FiO2 0.65. And what we did over here is we were actually able, because it's over distended, we decreased the PIP a little bit, kept the PEEP the same, and we decreased the eye time from 0.32 to 0.28. And we were able to decrease the FiO2 from 65% to 45%. Another example, I can see over here, 20/5 and 40% FiO2 by able to decrease, and what we did over here is we went down on the PIP to 18, and we were able to get the FiO2 down up to about 30%. So again, depending upon what the type of pathology or phenotype the babies have in severe BPD, we have to adapt our ventilation approaches to these babies. The other problem these babies have are BPD spells, and essentially they are bronchospastic cells, and essentially because of the fact that they have tracheomalacia and bronchomalacia. And one of the key things about handling BPD spells is not to just go there and either bag ventilate or increase the vent setting, it's sedation. We really need the baby to quieten down and relax so the bronchospasm is broken. And so sedation is the key part of doing the breaking the BPD spells. We do increase the PEEP a little bit and make sure the eye time is up enough. And then sometimes we need to add some bronchodilators and keep the tidal volume around 5 to 7 ml per kilogram. But I will highlight again that the key approach, or the first step in a baby who is going through a severe BPD spell and is hypoxic, is to sedate the baby so then we can get the baby a little bit better ventilated and oxygenated. So to remind folks about when we do tidal volume or volume guarantee ventilation, with early BPD, we tend to use around 3.4 to 4 ml per kilo. With evolving BPD is 4 to 5, and with established BPD, we tend to go higher, and even higher than 6 ml per kilo if the baby is having the cystic variety of severe BPD. It is important regarding oxygen saturation monitoring at what levels we want to target. So initially, we were doing improved neurological outcome. The studies have showed 90 to 95%. At the lower values, between 85 to 89, they have showed increased mortality. So we try to find a middle ground. And so right now in our unit, our targets are 89 to 94%, and we keep our alarm limits at 88 to 95%. And this is pretty much consistent till we reach established BPD. And then because of the concern of pulmonary hypertension, we tend to use slightly higher target ranges. Just to give you remind you of the strategies for what we do for prevention, or at least decreasing the severity of BPD. And then if you get established BPD, then how we try to manage. Here is a summary of the approaches. Initially, we use low tidal volumes and short inspiratory times. And then we adjust the targets that I mentioned. We are a little bit lower than this. We tend to do 89 to 94%. And of course, we allow for permissive hypercapnia. With established BPD, especially if you're talking about severe BPD, we will tend to have larger tidal volumes and longer inspiratory times, and we will have to handle the BPD spells. And again, we tend to use a little bit higher rates, higher targets of the oxygen saturation, around 92 to 95%, because usually the eyes are mature by this time, and we are concerned about pulmonary hypertension. So to summarize the invasive part of the management, and I will talk about the non-ventilation strategies at my second talk, which is after Daniel's talk. But here we tend to use, as I mentioned, targets of 89 to 94%. We avoid intubation as much as possible. If intubated, we give early surfactant, short inspiratory times, rapid rates, low PIP, moderate PEEP, and tidal volumes of 3 to 6 ml per kilogram. As much as possible, we try to extubate to NIPPV, and if the baby does well on NIPPV, then we go to CPAP. Here are our blood gas targets. We obviously use caffeine right from get-go because of the fact that it has been shown to decrease BPD. We will talk about all of these factors later. In the evolving phase, which is from 1 week to 36 weeks, pretty much the same target for the oxygen saturation, a little bit permissive on the CO2 over here in terms of our blood gas targets, but we will make every effort to try to get the baby out, get the endotracheal tube out to NIPPV, and pretty much the same for the methylxanthines, i.e. caffeine. For the nutrition is important. Again, we'll talk about that in my second talk. And here, preventive pulmonary hypertension, we used slightly higher oxygen targets of 92 to 95%. And these are our ventilator strategies. I'll talk about steroids and other stuff in my second lecture. If we are not able to get the kid off oxygen, we are able to send a baby home on oxygen. And this is just a list of 7 factors that we look at in terms of how we decide if the baby is ready to go home on oxygen. So baby has to be at least 36 weeks post-menstrual age. Most of the time, the baby are closer to 40 weeks of post-menstrual age. They should have no acute medical problem, no apnea. They should be immunized. They should have an optimal weight gain of at least 15 to 20 grams per kilo per week. And they should have no ROP that requires therapy. And obviously, we will need a baby that needs to be monitored in terms of their monitoring system because they're on oxygen. We usually send a baby home somewhere around 0.5 to 1 liter per minute. And obviously, it is 100% oxygen when we send the baby home in terms of the oxygen FiO2. The mainstay of trying to prevent, or if not trying to decrease the severity of BPD, is to get rid of the tube. And this is the strategy that requires the most attention, because here it is not just the data in terms of how you do it in terms of the numbers, but also there is a lot of art to doing this. And I'm going to try to give you some suggestions of how we do it that might be helpful for you as you manage these babies. So NIPPV is essentially giving CPAP in the IMB mode. And there have been lots of studies right in the 1980s showing that it decreased apnea of prematurity. And of course, when we had the infant star, we had synchronized, but at least in the US, we do not have synchronized NIPPV mode. How does NIPPV work? Essentially, it works by washing out the nasopharyngeal dead space. There's reduction of inspiratory resistance. It improves the stability of the chest wall. There's reduced work of breathing. It recruits the alveoli to open up the alveoli, so you establish a good functional residual capacity and generate, and you prevent the collapse of the alveoli and by keeping them open. Now, there is one of the modes of when we had a synchronized mode of ventilation, of nasal ventilation, we had the Grace P capsule, which was sensing the abdominal motion, and that would be synchronized with the baby's breathing. Detect it and synchronize the ventilator with the baby's breathing. But we do not have that machine mode anymore. The other mode of synchronized ventilation by using NAVA. I will not talk a lot about NAVA. I think Daniel will mention more about NAVA. So I did not want to repeat the substance of that. But basically what NAVA does, neurally adjusted ventilatory assist, what it does, it detects the effort of the diaphragm and sends the signal back to the ventilator, and then that helps in synchronizing the baby's breathing. I tend to use the nomenclature of primary and secondary mode of NIPPV, the primary mode being when it is used soon after birth, which may or may not be within 2 hours, depending upon when you need to give surfactant. If you keep the baby intubated for a longer period of time, for days to weeks, then you go and you extubate to NIPPV. I call it the secondary mode. The reason I distinguish between these two is because the ventilator settings recommended for both these numbers are different. So here are some of the settings. So when I'm ready to extubate the baby, the initial primary mode, when you're bagging the baby or manually ventilating the baby, I usually will use 4 centimeters of PIP higher than what pressure you're using to open up the lung. My initial PEEPs are 4 to 6, then I will go up to 7, maybe up to 8 if required. I try not to exceed these mean airway pressures. These are my maximum values. I'll keep around rate of 30, night time of 0.45 seconds and a flow of 8 to 10 per minute. If the baby has been ventilated for some time, then these are the settings I need, 16/5 and about a rate of 15 to 25 to get the baby to extubate. Once I'm ready to extubate, I will extubate to whatever mean airway pressure the baby is getting. The PIP will be 2 to 4 centimeters higher. And again, these are the numbers in terms of the PEEP, the rate, and keeping the same eye time. And again, I will try not to exceed the maximum values which I've mentioned over here. It is important to mention that all effort has to be made to prevent air leak. There's going to be air leak, not only from, if the prongs are nice, snugly fitting, that obviously helps, but the baby can open the mouth. So we make an effort to close the mouth, either by putting a pacifier or sometimes we'll put a chin strap. And these are the initial settings, but we listen to the baby, we listen to in the axilla to make sure the air entry is good. We look at the chest rise, we look at the oxygen saturation, and usually within an hour or so, I will get a blood gas and I will change or adjust the ventilator settings to make sure the PaO2 and the PCO2 are in the normal ranges as we have talked about earlier. So while these are the initial settings, I do increase the ventilator settings higher than if the baby requires them to be properly being oxygenated and ventilated. To give you an idea what happens when a baby is placed on NIPPV, here is an X-ray of a baby who was not on NIPPV, had been extubated on CPAP, and I put the baby on NIPPV. You can see very nicely the lungs have opened up. One of the important differentiation things that people talk about is when you compare NIPP with CPAP, they said, oh, NIPP is just similar to giving higher CPAP. That is not correct. Keep in mind that, yes, you are definitely giving higher mean airway pressure when you're on NIPPV. That is obvious from the fact that you are using higher PIP. But what is important to remember here is that when you're doing NIPPV, you are intermittently giving this higher PIP, which means it is not that the lung is constantly exposed to a higher CPAP. You could use CPAP of 8, 10, or even higher, but I would be very uncomfortable with that because I'm concerned about air leak syndromes. But when I'm using NIPPV, I usually have very rarely seen air leaks occurring on NIPPV is properly done because I do allow the baby's PIP to come down depending upon the rate that the baby is getting. And so this is the intermittent increase in the peak inspiratory pressure, which keeps the lung open. And even if the lung tries to collapse, the alveoli try to collapse, it will open it up again with the next breath. And I think that is why it works so nicely or so much better than just giving plain CPAP at a higher value. How do I do changes on the ventilation based on whether the baby is hypoxemic or hypercarbic? You can see over here, I tend to either increase the I time, and I will increase the rate. As you can see, I can go up to 40, and I will increase the PIP, and the P8 is usually the maximum I use. And the PIP, I have gone up higher, 30s even, 30, 35. But keep in mind that when you're increasing PIP, it's not the number on the ventilator, but what is actually being delivered to the baby. And so it is very important to try and decrease the degree of air leak by closing the mouth and making sure that the nasal CPAP interface is properly placed. And you do not want the difference between the delivered pressure, the CPAP that, or the mean air pressure that's going in and what you're giving, more than 2 to 4. If you find that you're putting a number of 36 or 40 on the PIP, for example, and you're delivering only 20, it's not going to be effective. So it is very important to try and keep the air leaks, the air leak in terms of the leaking from the nose and the mouth, as minimizing that as much as possible. Obviously, please always remember to put an orogastric tube, which is kept open to air, to make sure that the distension of the stomach is decreased. Because if you don't do that, if the stomach also blows up with air, besides the risk of perforation, there's also this pressure over the diaphragm from the abdominal contents, which will obviously affect your ventilation and gas exchange. So to summarize the model to reduce BPD, avoid intubation. If you have to give intubation, you can use Ensure. Hopefully, we will be using LISA, and then next, if the data looks promising. And then, if you're able to do nasal ventilation, keep on that. If you need to intubate, then try to do volume targeting. If it does not work, you can try synchronized IMV and pressure support ventilation. But like I said, there is sufficient data to suggest that volume targeting might be helpful. If the baby fails the non-invasive support, then we will try all of that. And if, again, attempts should be made to try and decrease or avoid intubation. And the focus should be in the first week of life. I will say more precisely, if you can keep the baby extubated between 24 and 72 hours of life, and we have data to support that, and try to prevent the baby from getting reintubated. And even if you do get reintubated, the risk of BPD definitely decreases if you have kept the baby extubated between 24 hours and 72 hours of postnatal life. So this is just summarizing the prevention of BPD, minimize hyperoxia, as we talked about already, nutrition, preferably human milk and vitamin A. You will hear about that from Danielle as well as from me later on. Early extubation, I cannot emphasize that enough. Preventing infection, inflammation is a keystone in the pathogenesis of BPD. So if you can prevent infection, that helps. Kangaroo care helps. And of course, if you are invasively ventilating, then we will at least try to decrease the biotrauma by all of these, trying to decrease baro, volute, and electrotrauma by the strategies that I have described in my talk. With that, I'll be happy to take questions down the line. And if you want to read more about BPD, I would suggest some of these books and chapters. Thank you for your time.
Thank you very much, Dr. Bhandari. So as you will be staying till the end, so we'll keep the question and answer for in the later panel discussion stage. So before we move on to Dr. Daniel's lecture, we will have a commercial break for 4 minutes, exactly 4 minutes. After that, we'll have the lecture of Dr. Daniel.